I welcome to our program this morning Dr. Frank Opelka. Dr. Opelka, being a fellow colorectal surgeon, has been a friend for well over 3 decades. Dr. Opelka worked at the Ochsner Clinic in colorectal surgery as well as at other institutions, and has for many years served the college in an unbelievably unparalleled, important manner as the medical director of the Division of Health Policy and Advocacy. Welcome, Dr. Opelka.
Good morning, and it's great to be here today. Just a shout out to all those in the field on the front lines who are facing this COVID environment. Our thoughts and prayers are with all of them.
Well, thank you, Frank. And you also were in the military, so I know that you understand front lines. That means a lot coming from you. So Frank, just as a bit of a background, because not every one of the viewers is going to be familiar with the essential activities that you perform, which I think prior to your tenure really hadn't been performed. So what is it that the ACS Division of Health Policy and Advocacy does prior to the pandemic, but what's the routine role? Perhaps you could just give us a thumbnail sketch of the importance of the ACS in Washington, D.C.
Yeah, that's a great starting point. So the division has 3 major arms to it to think about when it comes to dealing with national and state and regional healthcare. We approach things from a legislative approach. How do we actually get laws that are passed and support better patient care for surgeons and surgical patients? Then we have those laws turn into regulations, and those regulatory actions also need input. So how do we actually implement the law comes out into federal guidance or federal rules. And we work very actively with all the agencies like CMS, FDA, CDC, ARC, and so on, to help them write regulations that ultimately allow for a sensible or pragmatic implementation. It's very hard to write a one-size-fits-all rule for every situation in the country, and so we help give guidance in those areas. And the last area is, what's the next step of policy development? Healthcare is in massive transition throughout the entire globe. So what do we need to do on forefronts of redesigning health systems, payments, the use of digital information, and so forth? So we play an active role by partnerships and collaborations across the country with health policy institutes in developing policy that our leadership at the college then refines before we bring forward to reinstitute new laws, new regulations, and implement health policy.
Excellent. I appreciate that that overview. And speaking of collaboration, I know that the surgical guidelines and the admonitions against elective surgery were developed and fostered by the Surgical Coalition. Could you just explain to us what is the Surgical Coalition and what is the role of ACS in that coalition?
So all the surgical specialties come together in each one of the surgical disciplines, like colon and rectal surgery, neurosurgery, urology, orthopedics, and so on. And each one has their own approach for their own constituents, their own members, as they think through various aspects of their care. And in this case, in the COVID crisis, how do we actually contribute to the pre-planning phase in preparing a community to get ready for COVID? And so the college convened and helped convene all the input from all the specialties so that we could help frame a common message, not only back to the community, but to the federal government, to the states and local governors who are each trying to figure out how do we in this pre-planning phase implement and get ready for what's about to happen? How do we shut down elective surgery so that we can prepare the staff, repurpose surgeons, get folks ready for ICU onslaughts? There was an enormous amount of activity that had to come together throughout the surgical community, and the college was a convening force in helping guide that and message it back to the administration.
Thanks. Along those lines, as there are surges in some areas and other areas haven't had a surge or, God willing, won't have a surge, um, doctors have said, well, how do I help somewhere else? How was the ACS involved in ensuring that physicians could move across state lines without the usual barriers of long credentialing, licensing processes, liability? Could you explain that a little, please?
Yeah, great question. So we all know the limits of current credentialing, and the locality is so constrained that it's hard to imagine being able to move across state lines into other hospitals. So we worked with the Cures Act in getting language in for volunteers to be able to cross state lines under the Good Samaritan principles to provide and help provide care in a pandemic. And as long as this was in a volunteer status and crossing state lines, we could remove the criteria required for credentialing and other actions. If you are practicing within your license in a environment without any restrictions, you were able and free to move and share that same functional skill set in a COVID environment, even though it wasn't in, for example, your own state. So this is a very important part of the volunteerism, not just of the physicians, but of all clinicians, pharmacy, nurses, social workers. This is a broad scale repurposing across our credentialing environment that allowed us a lot of mobility and freedom we haven't had in the past.
How about within states? Because typically you say working across state lines is difficult, and it is, but sometimes working across the street is difficult, even if it's the same institution, but a different hospital within the umbrella organization. Have those barriers also been taken down?
Yeah, sure. Great question. Yes, in fact, we're seeing some examples of this as institutions have formed cooperative endeavors where they share intensivists, they share their ventilatory staff, they share their ability to manage the population, not as one hospital competing against another, but as teams working together. Where do you put the sickest of the sick? Who's learning from what are they learning, and how are they sharing, and how do they limit their resources so if somebody gets sick and goes down in one place, you can backfill that from another. All of those barriers have come down in the CARES Act and in the actions going forward. And we're seeing examples of it in New York. We're seeing examples of it in New Orleans. And I'm sure we're going to see examples of it throughout the country.
Thank you. That's excellent information and great work done by you and the rest of your team with the ACS in Washington, D.C. and throughout the country. The ACS helped develop guidelines for, firstly, a global recommendation against elective surgery, but secondly, guidelines within virtually every specialty and almost every disease type to help define and codify what might be urgent, what might be elective. Can you talk a little bit about the work done by the ACS and how that may have impacted the Vice Presidential Task Force in recommending reducing elective surgical procedures?
The advisors to the task force reached out almost immediately, realizing a need for a guidance document. And we put together a team of incredible experts and on call and almost immediately to begin working and framing principles that could be shared to the local community. We still think all these decisions are local between a doctor and a patient and a healthcare community, and they needed just a guidance principles and set forth a structure that would allow them to ramp up toward preparedness for COVID by ramping down their elective care. And then the thought being that as things began to tail off, they could reverse that process. And how do you look at the backlog and begin to unwind the backlog from the same prioritization? Because everyone's going to want to get back to work, but there's just a backlog of urgent care needs. So we're going to have to think through not only how we ramp up for COVID, but how we tail off. So the guidance document was structured to provide that element of thoughtfulness and principles at the local level.
Speaking of the local level, what can be done on the local level? A lot of people hear about federal loans that they're able to get if they're in smaller practices, rural physicians. How does all of the phenomenal work you've done trickle down on a local level?
The great question. That's been a lot of the work done by the legislative team led by Dr. Bailey, and their efforts put forth the ability to create things like hospitals without walls that would help create prepayments for hospitals and large systems so we could actually help with the burn rate of cash and get money back down into the local environment. The challenge has been, how does that local money spill down to all these practices, particularly surgical practices, which have shut down their elective care and shut down their normal cash flows? So not only is the care model shifted to this pandemic, but the business model is trying to catch up so that we can have a workforce that gets repurposed, and we can have a workforce that at the end of this and tails off, we can restart and get back to where we were. There's lots of problems and challenges still as we're finding out in getting the money flowing. And I know the administration is very interested in how can we further aid the surgeons, the local communities, the smaller docs in rural areas, as well as in these large communities that are being stricken with the pandemic. How do we actually create a cash flow that doesn't have them all burning through resources, which are becoming preciously few?
Thanks. And then one thing you touched upon is the restoration phase, that there is going to be life after COVID-19, and so how will we get back to that life? Plus, will some of these things be left in place or potentially left in place? People have discussed a second wave, and if this becomes either bimodal or even seasonal, will some of these things be left in place so they can be more quickly mobilized and enacted in the future if needed?
Wow, is that an incredibly complex and dense question? There's so much in there. The whole way that we approach this is we try to stay 4 to 6 weeks ahead of where the pandemic is. That was the pre-planning phase. Now we're in the peak phase and the cresting of this. And so we're trying to go 4 to 6 weeks down the road. And at the same time, in every one of these steps, we're also looking for unintended consequences, gaps we didn't cover, failure points, because we're going to have to deal with all of that. And they're just much more common in crisis than they are when you're in a steady state of care and a steady state of business. So we're expecting, as the tail comes on, we've got real challenges as to how do we look at what we've learned from the pandemic, what do we keep, what do we throw out and return to the status quo, and how do we actually kickstart that? How do we restaff the business models that we know that work? How do we de-evolve the business models that we needed to get rid of because they just weren't working in the long run anyway? So there's a whole lot of questions about what do we need to, what are the lessons learned, what are the after actions, and what does the restart and refresh look like? Those are unanswered. Those are going to be legislative issues in the next round of COVID stimulation, if you will. And we are working with the Congress now to try and think through that. We are getting news from the fellows who need help, and we're trying to build a case for their support. And we're looking for ways that we can actually help as the restoration begins, that allow our fellows to get back to the best care available for patients.
Well, we know that with you at the helm and with Dr. Patrick Bailey on the legislative side, we can, and with Chris Shaligan helping out, obviously, that these things will get done and will be appropriately thought through, and the college will be called upon to assist in these processes. So, Dr. Opelka, on behalf of the fellows, you certainly have my gratitude, all of our gratitude for the incredible work you do year-round every year. certainly risen to the occasion to help all of us, help all of the patients throughout the country through this pandemic. Thank you very much for what you've done. I wish you and your family, your loved ones, health, sustained safety and health through this pandemic, and look forward to seeing you in person whenever we reconvene our meetings for the college.
Thanks so much, Steve. It's really been an incredible team. We've got the best, I think, in all of Washington. We have the respect of the administration and the Congress, and it is because of the efforts of the regents and our leadership that we've been able to garner that respect. So, and best wishes again to you, to your family, to the entire college family, and all our fellows who are out there in the front line doing all the hard work.